What a clinician must know about eosinophilic esophagitis. Eosinophilic esophagitis is a chronic immune-mediated disorder that involves the esophagus. Dysphagia to solid foods and food impaction are the common symptoms. In children, in addition to that, feeding dysfunction, vomiting, and abdominal pain are also seen. Feeding dysfunction in children is an increasingly recognized presentation of eosinophilic esophagitis. It includes failure to develop normal eating patterns and adopting coping strategies like refusing to eat solids after previously eating them, eating slowly, chewing excessively, drinking excessive liquids with meals. How to diagnose? In patients suspected of having eosinophilic esophagitis, the first diagnostic test is upper GI endoscopy with esophageal biopsies. Its endoscopic features are a variety of morphologic features in the esophagus have been described, among which multiple rings in the proximal to mid-esophagus giving the appearance of a trachea, and small whitish papules visible in this picture represents eosinophilic abscess on histology. A linear furrowing that may extend the entire length of the esophagus and strictures, particularly proximal strictures, are also seen. And barium swallow in a patient with eosinophilic esophagitis shows mild segmental ring-like areas of narrowing in the proximal and mid esophagus. It represents the trachealization of the esophagus. Modes of treatment. There are three main modes of treatment are available. One is dietary therapy, second is pharmacologic therapy, third one is dilatation of esophageal strictures. Dietary therapy. For most patients, a 4-food empiric elimination diet is recommended. The commonly eliminated diet are cow's milk, hen's egg, wheat and soy protein. Cow's milk is the most common food trigger for eosinophilic esophagitis in children as well as in adults. The initial elimination diet is typically followed for a period of 8 weeks. Symptoms are assessed and a repeat endoscopy with esophageal biopsies is performed at the end of the initial avoidance period. Then foods are introduced slowly one at a time with a periodic evaluation to determine if each food is tolerated. Pharmacologic therapy is recommended in a patient who fails an initial elimination diet. Pharmacologic therapy, proton pump inhibitors and topical glucocorticoids are commonly used drugs. So initial pharmacologic therapy is started with proton pump inhibitor for a period of 8 weeks. Then upper endoscopy performed after 8 to 12 weeks to assess the endoscopic and histologic response. Topical glucocorticoids. Most patients with eosinophilic esophagitis respond to topical glucocorticoids as demonstrated by a decrease in the eosinophil counts. Fluticasone and budesonide are commonly used. Fluticasone propionate is administered using an metered dose inhaler without a spacer. The medication is sprayed into the patient's mouth and then swallowed. Patients should not inhale when the medication is being delivered, and they should not eat or drink for 30 minutes following administration. The optimal dose has not been established. For children aged 1 to 11 years, 110 microgram per spray, 8 sprays daily in divided doses 2 to 4 times a day. For children more than 12 years and for adolescents, 220 microgram per spray, 8 sprays daily in divided doses. Then budesonide can be administered as an oral viscous suspension. The dose is 1 milligram daily for children under the age of 10 years and up to 2 milligram twice daily for older children and adults. And viscous budesonide can be prepared by mixing 2 or 4.5 milligram per 2 ml residuals with sucralose. Sucralose is available as a 1 gram sachets. So it can be mixed with the sucralose, creating a volume of approximately 8 ml. And patients should take the budesonide slowly over 5 to 10 minutes, and they should not eat or drink for 30 minutes after taking the budesonide suspension. Options for non-responders are Dupilumab is an interleukin-4 receptor antagonist that has been approved for use in the United States for the treatment of eosinophilic esophagitis in adults and in pediatric patients who are 12 years of age and older and they weigh at least 40 kgs. Dilatation of esophagus is effective for relieving dysphagia, but it has no effect on underlying inflammation. It is often reserved for patients who failed more conservative therapy, but it may be required as an initial therapy in patients with high-grade strictures. Thank you.